Recording. Okay, welcome to our first fall edition of the Nevada Cancer Coalition Cell Series. Today we are featuring Bailee Daniels and Allison Faust from Huntsman Cancer Institute at the University of Utah, and they will be presenting on the Community Health Assessment Survey, which is uh, an assessment of patients in rural and frontier areas, focusing on some of their barriers to healthcare. It was kind of covering all sorts of things about clinical trial and treatment and access to care. So we are going to get started on that. I wanted to start with a little bit of housekeeping. We have Q&A and a webinar chat. You can use either of those to drop your questions in. We're going to hold questions until the end because we've saved time at the end for that. So if you have a question, feel free to drop it in either of those, and we will get to those at the end. If we lose any sort of connection, just log back in and we'll start again. We're also recording this session, so you'll be able to review it in the future on our YouTube channel. So I'll just introduce our speakers. We have Bailee Daniels, who is a Senior Manager of Population Sciences and Community Outreach and Engagement at Huntsman Institute for Cancer. She's also a certified clinical researcher for the Precision Exercise Prevention Study, and was previously a medical assistant and worked in a clinical capacity. We also have Allison Faust, who is part of the Huntsman engagement team, community engagement team, and she is a certified health education specialist, and was actually raised in rural Nevada. So she knows a little bit about our state, and some of the unique challenges that we have. So I'm going to turn it over to Bailee to get started.
Thanks, Kristen. I appreciate the wonderful introduction. Hello, all. I am Bailee Daniels, as Kristen mentioned. Sorry, let me make sure that I have everything prepared for my point of view. Okay, you should be seeing my actual slide deck, but of course, feel free to chat if that's not the case. As was mentioned, I'm a senior manager within population sciences at the Huntsman Cancer Institute at the University of Utah, and I'm primarily presenting on behalf of Dr. Tracy Onega, a senior director for population sciences at the Huntsman Cancer Institute at the University of Utah. This was led by her, but then I provided project coordination, project management on her behalf. So without further ado, we have completed a community health assessment survey that assessed the health needs in rural and frontier communities. And while this is all encompassing over the area we serve, which I'll expand on and explain in just a moment, I'm actually providing you the data specifically for the state of Nevada. So it's not across the full data set. So I think it's important to understand Huntsman Cancer Institute. So I'll be just providing some quick information in terms of our mission and vision. And of course, this wonderful picture of our beautiful hillside that we're really lucky to have. And then we'll dive in more so into the survey itself. So at the Huntsman Cancer Institute, our mission is to understand cancer from its beginnings, use that knowledge in the creation and improvements of cancer treatments, relieve the suffering of cancer patients, provide education about cancer risk, prevention, and care. Our vision is passionate individuals and teams delivering a cancer-free frontier through scientific discovery and human touch. And this is the Salt Lake Valley for those who have not been able to visit. Okay, so a little bit of background in terms of our catchment area, or the area we serve, which I just briefly mentioned in the introduction. This you can see is a large map of the United States, right? But then the states highlighted, of course, Utah in orange, and then the states in blue. That's our area we serve, our catchment area. So you can see that there's those little blue dots. Those are the National Cancer Institute designated comprehensive cancer centers. And basically that's a special designation designation. Not all places that provide cancer care have that. It's specifically given by the NCI. And with each cancer center, we have to formalize our catchment area, or what we like to call the area we serve. And this is a geographic area that each center serves through research, clinical trials, and community outreach and engagement. So initially, Huntsman itself, Huntsman Cancer Institute, the area we serve, was just the state of Utah, with increased work happening within the region. But then in 2021, we formalized our commitment to the 5-state Mountain West and expanded the area we serve to include Idaho, Montana, Nevada, Utah, and Wyoming. This brings a lot of opportunity and challenges, especially in terms of monitoring our catchment area. So partly why, the impetus for CHAS, or the Community Health Assessment Survey. In terms of the area that we serve, it includes 169 counties. Of these, 158 are rural, with fewer than 100 people per square mile. Utah, Idaho, and Nevada are all ranked among the top 5 fastest growing states. Many patients travel more than 150 miles to be cared for here. And the Mountain West itself includes 524,000 square miles, which is 17% of the continental US landmass, and it contains 10 million people. So now, giving that context, which I think is important to understand, because I will be referring to area we serve throughout this presentation, that was the purpose of that. Okay, so pivoting just a little bit, I mentioned for the area we serve that we do need to have a system or a solution in place to be able to monitor needs within the area we serve. And that's where our System for Health Assessment and Population Equity, SHAPE, comes into play. And this was funded by the NCI P30 supplement. So this system uses a variety of publicly available data, clinical and restricted data, and primary data collection, CHAS, which we use to create this data integration platform, which monitors key cancer control domains, such as those shown on the right, to assess the impact. A critical aspect of this is central to our efforts, which is the Community Health Assessment Survey. And you can see in the top right corner, there's our measurement and metrics that we hope to monitor, or that's what we plan to have included within our platform, but then also the availability to query, map, and have an analytical portal, which we may be able to also make publicly facing. That way individuals can go on their own and to complete their own queries and maps if they'd like. So I wanted to give that little information a little bit in terms of SHAPE. And then, because, with the Community Health Assessment Survey, this is a primary point or collection data point for assessing the area we serve that will be contained within the system. As you can see, we plan to have multiple iterations of the CHAS, but today I am only going to be discussing round 1, the rural and frontier populations, and I'll be briefly discussing the Hispanic round 2 Hispanic Latino populations. That one is currently in progress in terms of data collection, but we'll talk about that at the end. So this is round 1, as I mentioned. This was the first ever survey of frontier populations in the Mountain West. Wyoming and Montana are especially characterized as vast frontier areas. So there were a number of steps that had to be taken for this to be possible. For example, regular survey companies do not have access to adequate data for sampling frontier populations. This was really disappointing, but we did find that the Wyoming Survey and Analytics Center has the ability to find individuals who would be eligible for the survey. We use state-of-the-art methodologies to obtain data, including on science-related beliefs. The survey allowed for online and mailing options and took approximately 15 minutes to complete. We used address-based sampling and probabilistic sampling, oversampled for rural frontier with snowball sampling and/or convenient sampling to reach targeted numbers for harder-to-reach populations. The survey was possible in large part due to our partners, including Lilly Helzer and Amber Heiss, specifically for the Nevada data. There's a data transfer agreement currently in progress, and just a huge thank you to all of our partners, especially Lilly and Amber, for your involvement. And I'll explain further how they were involved in another slide. So before we get into more of the specifics of the survey, it is important to understand the rural and frontier areas within Nevada. So using the frontier and remote or FAR zip code areas from 2010, they just haven't been updated yet. FAR, as you can see on the maps, FAR is shown in blue, and then the non-FAR is shown in gray. So level 1 is the least remote. Level 1 includes zip code areas with majority populations living 60 minutes or more from urban areas of 50,000 or more people. Our level 2 is a more remote. So this includes people living within 60 minutes or more from urban areas of 50,000 or more, and 45 minutes or more from urban areas of 25,000 to 49,999 people. So not much of a difference here in terms of 1 and 2, but then we get to 3 and 4, and that's where we see some changes here. And again, we're getting more remote. So FAR level 3 includes zip code areas with majority populations with the previous categories, as I've mentioned, but also 30 minutes or more from urban areas of 10,000 to 24,999 people. And then FAR level 4 is all of those categories I've already mentioned, but also they live 15 minutes or more from urban areas of 2,500 to 9,999 people. So the most rural, the most frontier are level 4. So I mentioned that we had our partners that helped in the development of the survey. They were key in making this as successful as it was. Just in terms of the survey domains, we had asked our partners what they felt would be most interesting to their states or most valuable. And ultimately, the domains that were shared among all partners were what was included in the core survey domain. And then in that core survey, we allowed for state-specific supplemental surveys, which individuals that were provided the specific link based on their zip code that they entered into the survey. So individuals who were from Nevada, in theory, should have only received the Nevada supplemental survey. That was optional, but we still garnered a lot of responses from that, and I'll explain that more. In terms of the supplemental survey domains, you can see those on the right. So we consider primary data collection through CHAST to be absolutely necessary to understand the heterogeneous and unrepresented populations in the area we serve. The case in point is illustrated by national survey data that we rely upon to inform key domains and measures. For example, in the HINTS data, which is NCI's Health Information National Trend Survey, the number of respondents per state is very small, and it's just not representative of our communities in ways that informs our ability to serve them. So in our first round of CHAST, we can see that we're reaching all 5 of the states in the area we serve, and our oversampling methods for frontier populations is reaching even the most frontier and remote populations. This is really exciting to see. So first, you can see in the upper pie chart, we're reaching all 5 of the states, and I pulled Nevada out specifically to really highlight it. And then on the bottom graph, or excuse me, pie chart, you can see that there's the frontier areas or FAR areas, and with 1 through 4, 4 being in the most remote. And we see that we're unique in successfully reaching individuals in these areas, with over 93% of respondents living in frontier and almost 20% in the most remote FAR level 4. But again, this is for the full data set, and I will be pivoting more into Nevada right now. In terms of the Nevada-specific demographics, you can see here that majority of respondents were white, male, but then with age distributions, it was fairly distributed across all age categories. So we talked about the primary purpose for Huntsman with the area we serve and trying to understand it better, right? But I think it's important to understand from a patient's perspective, which is why I've included both of these articles here. One of them is Gordon Sorensen, who was highlighted in the Huntsman Cancer Institute communications team. He was interviewed regarding the survey. Same with Casey Shakespeare from the Salt Lake Tribune. So I'll be referring to them briefly throughout the presentation today. But first, I'd like to start with a quote from the communications article regarding Gordon Sorensen. Quote, "This unique data set helps clinicians to better understand how to best help patients like Gordon Sorensen, who runs heavy machinery and lives with his wife in Swan Valley, Idaho, tucked between the Snake River and the Grand Tetons. We are living the good life here," says Sorensen. "I'm happiest in the middle of nowhere." Sorensen was diagnosed with follicular lymphoma in 2015. During his treatment, doctors noticed a small spot on his right kidney. Sorensen had been experiencing back pain, which he initially dismissed until he woke up with numbness from his chest down. An MRI showed a cancerous lesion had eaten away at his upper vertebrae near his shoulder blades. The spot on his kidney had grown through his artery and traveled through his bloodstream to his back. He was immediately flown to Huntsman Cancer Institute for surgery. And for Casey Shakespeare from the Salt Lake Tribune article, quote, his son Isaac, now a 2-year-old, was born without kidneys, a rare condition known as bilateral renal agenesis. Isaac spent the first 6.5 months of life in intensive care at Lucille Packard's Children's Health at Stanford in Palo Alto, California, almost a 12-hour drive from Shakespeare's St. George home. So access to care was mentioned as a struggle for both Gordon Sorensen and Casey Shakespeare, which highlights the importance of being able to have this domain within the survey. I'll begin with providing with Gordon's experience. Quote, once stable, Sorensen traveled back and forth from his home in Swan Valley to Salt Lake City every 3 weeks for kidney cancer treatment. It's a long day of traveling, especially when you're not feeling well, says Sorensen. We've had times where we left our house at 3 o'clock in the morning, drove to Salt Lake, went to appointments all day, and then drove home. It amounts to about 14 hours. Doctors treated Sorensen's slow-moving and common type of non-Hodgkin lymphoma with radiation, and it hasn't given me a minute's trouble since then, explained Sorensen. Sorensen echoes the study's findings and has seen firsthand the impact that lack of access to care can have on those diagnosed with cancer. He's seen many community members struggle to travel to their appointments, end quote. So now we'll get into the data, which is exciting. So using the preliminary data, we're learning that only 37% of the Nevadan respondents agree that they have easy access to medical specialists, and 48% find it hard to get an appointment for medical care right away. 36% agree that they think their doctor's office has everything needed to provide care. For the graph on the right, when asked what would improve healthcare access in their communities, 83% indicated visiting specialists were key. This actually aligns with Shakespeare's experience. As you mentioned, they still travel 4 hours each way to continue care for their son at Primary Children's Hospital to receive specialized care, and that's from the Salt Lake Tribune article. The blue boxes indicate areas where Huntsman Cancer Institute could potentially make a substantial difference, which are availability of walk-in clinics, improved or better quality of care, telemedicine, and I think I got them all. Okay. And this, in terms of the survey sample for Nevada, it achieved a total of 168 respondents. I don't think I mentioned that previously. Okay, so additional results that illustrate that for cancer screening and care, frontier populations are willing to travel long distances, as Casey and Gordon mentioned in their experiences. In fact, 30% of patients seen at Huntsman Cancer Institute travel over 150 miles to receive care, some of them even 500 miles by car. I'm not sure if many of you know, but traveling across the Mountain West by car can be hugely challenging during the fall, winter, and early spring. Freeways can be closed and the weather can be pretty unpredictable. So here we can see that for both cancer care, 160 minutes, and cancer screening, 70 minutes. Frontier populations are willing to invest time. This demonstrates the value that the topic cancer has for these populations. 33% of individuals living in the most remote areas indicate that they can get the healthcare they need near their home, and a third of all frontier populations overall have that challenge. The Salt Lake Tribune article highlights Casey Shakespeare's experience. Quote, Shakespeare, who is also the Assistant Director of Community Programs for the Utah Center for Rural Health, said focusing on prevention is key. In places like Garfield County's Tropic, where he grew up, the tendency is to put chores and other responsibilities ahead of a trip to a doctor. Working to change that culture to nip it in the bud before it gets bad, Shakespeare said, means finding ways to reduce travel times, especially for cancer care, end quote. In terms of medical care, participants were given statements pertaining to medical care and how much they agreed with each statement. You'll see less than 47% felt doctors were good at explaining reasons for medical tests. 32% agree the medical care they're receiving is just about perfect. 48% agree sometimes doctors make them wonder if their diagnosis is correct. 44% agree doctors sometimes ignore what I tell them, and 39% agree they have some doubts about the ability of the doctors who treat me. Neither Casey or Gordon referred to the quality of their care in either article. In case you don't know, prevention is primary defense against cancer. Both refraining from cigarettes and completing cancer screenings based on screening guidelines is crucial. Smoking cigarettes is the leading cause of preventable death in the US. It causes 90% of cancer deaths and causes cancer in various other regions of the body, according to the CDC. But good news is 90% of individuals surveyed do not smoke cigarettes every day, some days or not at all. 39, in terms of screening though, 39% have not received or are not current with their colonoscopy or sigmoidoscopy, and 85% have never or are not current with a blood stool test like Cologuard and FitDNA. 42% of women within screening guidelines, which is 40 to 74 years old, have never received or are not current with a mammogram. Screenings like colonoscopies, sigmoidoscopies, and stool tests for colon cancer and mammograms have the potential to detect these cancers early, which in turn we hope would reduce overall travel time because maybe treatment could be, a little less depending on the cancer type. Okay, so frontier populations, we really wanted to understand how they receive health-related information in their community. This was really interesting. We found that they do not often use social media platforms for health information. TV and radio are also not ways to disseminate health information. Friends, family, healthcare providers, word of mouth, and the internet are actually the main sources of ways that they receive healthcare information for frontier communities. Our preliminary results indicate that 39% of respondents have to pay for more medical care than they can afford. 36% feel confident they can get the health care they need without being set back financially. And they're mostly unaware of programs to pay for health care. According to the 2022 CDC census, 12% of individuals in Nevada are living in poverty. This can be very stressful and might result in having to choose between receiving care versus some other high priority item, which may be a real experience for some of these people. The situation happened to Shakespeare in particular. Quote, "We were in a tough spot because we couldn't actually afford to live in Pasadena or Palo Alto long term," Shakespeare said. Southern Utah's booming housing market at the same time meant that if they sold their home, they wouldn't be able to buy again for at least a year. End quote. These results suggest that he isn't alone in his experience. Okay, pivoting into terms of knowledge of community resources for cancer survivors, also for individuals with cancer. So in terms of knowledge of community resources available for cancer survivors, it's really low, unfortunately. So with even the most well-known resource, which was understandable information in their language, was under 20%, followed by emergency, financial, mental health, and food nutrition assistance. Knowledge of cancer resources for people who currently have cancer was also low, with the most available resource known at 36%, which was understandable information in their language, then emergency and transportation assistance. We do know, I think most of us, that there are some resources available within the communities, and we wanted to understand what resources the survey respondents were aware existed and what they felt was needed. So for health screenings, education, or free services currently available in their community, you'll notice vaccines are the most known available resource they were aware of, followed by exercise, physical activity, then nutrition. Many don't know cancer cessation are available. And cancer, tobacco cessation, and vaccines, cancer, tobacco cessation, and vaccines are needed in the community based on what the respondents have mentioned. So we did also find that majority have access to internet by paying a cell phone company or internet service provider. 77% have access to, or they access the internet daily via a mobile device, whereas 54% access it via their computer at home, and 28% access the internet via computer at work. And in the past 12 months, respondents use their computer, smartphone, or electronic to look for healthcare or medical information for themselves. That's 77%. Use email or internet to communicate with a doctor or doctor's office. That's half. Same with looking at medical tests, also 50%, and then made appointments with a healthcare provider, only 43%. So that was all of the data that I was able to share with you today. There's still, of course, many other domains that we included, but that's what I was able to fit within the time. I did also want to, as I mentioned, give a little bit of information in terms of our round 2, which is the Hispanic Latino focus. We are partnering with the Alliance Community Services. We found that this was the next population or individual group of individuals to survey, as they make up 13% of Idaho, 4.2% of Montana, and 28.7% of Nevada, 15% of Utah, and 10% of Wyoming. We'll be distributing it 2 ways: with community health workers, with the Alliance Community Services, and then social media advertisements. If you have other ideas, if you're interested in learning more about this data, please reach out and we'd be happy to discuss further. Okay, so if you're wondering at all what our next steps are currently at the Huntsman Cancer Institute, that's where I'll be focusing now. As I mentioned, this was preliminary data, so we're currently conducting a full analysis of the data, and we're really looking forward to sharing the results with, of course, our partners and the NCI. We're also open to further collaboration regarding the data. So again, please feel free to reach out if you are interested. Feel free to email me directly. But there's also been really substantial interest among elected officials within the area we serve. So our offices have been really working hard, our communications team, to reach out to them and provide the data as it's being developed. We've also been discussing with leadership and the HCI Community Advisory Board, which should be taken next. Of course, we're doing the data transfer agreements, but we're also hoping to, we're currently in the process of creating more appropriate education about clinical research and clinical trials. That's not something I expanded on in this particular presentation, but something that we found that majority of our respondents did not know what a clinical trial was. So that's something that we're primarily focusing on. And we're also having some focus groups in terms of culturally appropriate interventions in hopes to increase trust, and then maximizing the efforts to share with the DTAs, with our partners via the DTAs. So I think those are the primary mechanisms that we've been doing, but of course presenting to you all today. And I don't think I could think of anything else beyond that. All right, I'm happy to answer questions, unless Kristen, if you wanted to have Allison go next and then do questions, that's fine with me too.
We don't have any questions dropped into the chat or the Q&A yet. So if Allison wants to get started, if you do have any questions, go ahead and drop them in. I know I have a few, but let's go with Allison and then move on with questions after that. Thanks.
Okay, great presentation, Bailee. I've heard you speak several times, and I feel like every time I learn something new. So thanks for being here. As Kristen said in our introduction, I'm with the Office of Community Outreach and Engagement. That sounds like such an abstract sort of term. So I wanted to talk a little bit about what our office specifically does and how we're planning to use the CHAZ data to work with all of you as a part of Cancer Coalition Network. So our Office of Community Outreach Engagement across Huntsman Cancer Institute does a variety of health events, community-based presentations around prevention, screening, treatment, things like this, data sharing. We have patient navigation services, mobile cancer screenings within the state of Utah, and partnerships with your screening bus in the state of Nevada. Putting in a plug for a screening event happening in Wendover in October, the end of October, where we'll be having both mobile screening buses on the state line to be able to meet the needs of the communities when we have borders that restrict our services in our state. So just putting in a plug for that on the 30th. Additionally, we also do community education on clinical trials. We help support with coalition strategic planning and research. And then we do have specific programs such as our American Indian program that work with tribes across our 5-state area. Specifically, what we're excited for, having these data from Bailee and her team, we are really excited to look at the specific issues of rural and frontier areas. I think, as Bailee sort of demonstrated, the data that we've had access to in the past was very underrepresentative of the needs in our area. And so to be able to hear from all of you and your populations is really exciting. And I think we'll be able to select priorities to highlight in our state cancer plans with all of you. I think it'll help us be able to customize messages that resonate with your rural areas and your frontier areas in our 5 states. I think we'll be able to sort of explore some of the gaps in access, whether this is through mobile health clinics, telemedicine, additional partnerships in healthcare. We're going to continue to engage with local stakeholders to share these findings. I think some of that will probably include policymakers and other stakeholders that have influence to create change. And then this also gives us another data point to track progress. I think one of the hardest things in prevention, those of you that work in prevention and community outreach, we see results in 10 years, 20 years, right? And it's really hard to measure the impact of our work. And there's so many unique data points in the CHAZ survey that I think will be really helpful to give us a baseline of where we're at. And hopefully we can continue to evaluate that over time. I feel like it would be a missed opportunity if I didn't highlight some of the other services. So in addition to, how we're planning to use the CHAZ data, there are a lot of other services available to you all in Nevada that I wanted to talk about. So for those of you that are not aware, Carson Tahoe Health in Carson City, Nevada is actually a Huntsman Cancer Institute affiliate site. And essentially what that means is we're able to help them with improving access to cancer care, clinical trials. They can learn from our providers and our researchers and really collaborate together when it comes to cancer prevention, education, and treatment. We also have the Center for Health Outcomes and Population Equity. Now, this really is a research infrastructure and sort of the bridge between scientists and community-based organizations in the Mountain West. There are several projects that they're working on in Nevada that I think are really exciting. Some of them specifically with the Nevada Cancer Coalition and other community-based partners around food security, adolescent tobacco use. I believe there's some work going on with some of the dental industry within your state as well. So really exciting to sort of see the research and funding side of things start to build. One thing that people don't always know about that I wanted to highlight is that we also have a patient navigation team at Huntsman Cancer Institute where they're able to provide tailored support to folks in Nevada and our other states when they're diagnosed with cancer, how to help them sort of navigate the system, reduce barriers when it comes to access to care. So whether that's language or culture or distance or connecting to financial resources, they can help with all of these. And many people don't realize that those are available to people outside of the state of Utah. And so we specifically have a patient navigator that is focused on rural and frontier areas. And so that is her specialty. So I wanted to specifically highlight this service. And of course, you're welcome to reach out to me for any of the things we talk about today, and I'll point you in the right direction. You don't have to remember all these names and faces. And then sort of lastly here, I wanted to highlight the Cancer Learning Center. This is a free service where you can chat, email, text, call, whatever makes sense for you, or even visit us in person if you're here on site. We have services in English and in Spanish, but you're able to access the library, services and just learn various things about cancer. We do have cancer information specialists there to help answer any questions that you have. And this is a great service that people are not always aware of. The last thing is I'm going to put in a plug for you to join our Mountain West Cancer Collaborative. We started this in April of this year, but really the goal is to be able to connect prevention, treatment, research professionals across the 5-state area that we serve as the designated comprehensive cancer center for those 5 states. We want to help you all convene and collaborate and share ideas because we do experience unique challenges, but we also have unique strengths, I think, out here in these communities, and we want you to be able to learn from one another. And so we have formed the Mountain West Cancer Collaborative. We do monthly newsletters sharing information happening throughout those 5 states. We also have a quarterly webinar series focused on topics that you all have identified as important to you. And then lastly, we are in the midst of forming some ad hoc action groups focused on cancer screening, cancer coalition leadership. So that will be focused on the new iteration of state planning, clinical trials, community health workers, policy, and then there will be a work group specifically focused on action items for CHAS and SHAPE. So kind of excited to see where that goes, but would encourage you to take out your cell phones and use this QR code to sign up for our email list. I promise I do not overburden your inbox. I will send you one email a month, I promise, maybe 2, but we try really hard to be respectful of your time. But think that this is a great opportunity for you to get involved more with HCI and your counterparts in other states. So that is all that I had to share. So I think we have a few minutes left to open up for questions. Thank you all so much for being here.
Thanks, Allison. That was awesome, both of you. Thank you, Bailee, as well. I don't see any questions dropped into the chat or the Q&A yet. So if you have any, just drop them in. I know I have a couple. So I wanted to check, this is a question for Allison, but it goes back to data that was presented by Bailee, which was on how people receive their health information. And it was indicating that in the rural communities, they're much less likely to get it from the internet or TV or radio or social media. And so those are many of the ways that we have to actually reach those communities, and yet they are getting it from word of mouth and friends and family. So has your team thought of ways to actually get that information out to people who can spread it word of mouth and to friends and family to get it to the people who need it?
Wow, that's a great and really difficult first question, Kristen. I mean, I will say these data are very new to us as well. And so that is sort of why we are forming all of these ad hoc groups, or to kind of focus in on what elements we can actually have make a difference in. And I do think community education is one of them. But I think it will lead to some reframing of how we are talking to the community. So I know that's not an answer, but I think that we probably will see some expansion and some changes because it was interesting. It was interesting to learn. I don't know, Bailee, if you have anything you want to add.
No, I think you said it perfectly. Yeah, I think our next steps hopefully will be able to allow us to assess that better and to have a better understanding of ways that would be most effective, especially with the working groups.
Yeah, I'll note that our outreach team actually has had great success with going to some of the community health events in rural communities. I know there's one at Mount Grant General Hospital in Hawthorne. There's a huge one in Elko every spring, and thousands of people turn out to those events. So perhaps it's just more of a focus. I mean, short of getting a town crier to walk around with a little megaphone, which I don't know, maybe we'll have to resort to that. The other question I had is, so this week I read an article in Newsweek, and it was more the same news that we already knew, which was that Nevada is among the lowest for healthcare access in the nation. We have, a shortage of providers basically across all sorts of different areas, primary care, physician assistants, nurses, specialists, et cetera. We have, insurances, expenses, and lack of insurance. But Utah is number one on the list for worst, and Nevada is number two for worst. And so we're in the same boat. And I know that, reducing that physician shortage is going to be a long haul because you've got to get people in the pipeline educated. But, with telehealth, there is that option, but there's also a need for those in-person specialist visits. Um, do you think that Utah has the capacity with its specialists to be able to do some sort of a satellite program? I saw a model in Georgia, in rural Georgia, where they had a hospital in Savannah and they had an oncologist that would go to different communities on a regular schedule. So on Monday, he'd go to, this community, and on Tuesday, he'd be in this community. And they partnered with clinics to be able to provide that specialty service. Is that something that would ever be, I think, do you see that as something that would be possible and or useful for some of your catchment area?
Yeah, I mean, I think a similar model has worked with our University of Utah visiting practitioners, right? Many of your rural areas like Elko get University of Utah derms and other providers that come and visit. And so it's certainly something I think the University of Utah is supportive of. It's just I think HCI sort of formally expanded our catchment area it's only been about a year and a half. And so now I think we will slowly see services expanding as well. I think we're looking to utilize our affiliate hospital networks. And I definitely think it makes a lot of sense. We're just sort of in that process, I think. But I think the long-term goal is to have people in each of these states doing this work so that it's not us always having to send people.
Yeah, I agree. The relationship that a provider has with their patient is really important to building trust. Is there any other questions? I don't have any open questions in the chat, and I have nothing in the Q&A. And I didn't have, oh, I did have one more question. Sorry, I have one more question for you. The data with the legislators, you said that you talked with policymakers and shared some of the data. Do you see that as providing them some motivation to move forward with policies that are going to help to increase possibly, the healthcare pipeline and provider capacity? I mean, did they seem excited about it in that sense?
Unfortunately, I am not within that grade to be a part of those conversations. But from the information that I've received, it sounds like they have been interested. They've expressed, because we initially mentioned this to them when it was in development. So from my understanding at that time, many of them were really interested to learn what the results were. And I know that it's Ashley Harrison. She's the individual who is meeting with these individuals, and it sounds like it's been successful so far. What that means, I don't know, but there's interest, which is good, right? That's a good start.
Yeah, but I think we would also love to see you all utilize the data and take it to your legislators as well. And of course, HCI will support where we can, but would love to empower you all to do that.
Yeah, absolutely. I know that was on the radar during our last legislative session, is getting some of our provider capacity policy moving. So we'll see what shakes out starting in February. Well, we don't have any other questions, so I will give you guys back 1 minute of your time. Thank you so much for presenting on this data. It is so interesting. Really loved all of that information. I can't wait to see what comes out of the next phase of the research, and anything moving forward from that, I think it's just going to be really helpful for all of our partners to do a better job of preventing and finding cancers earlier and taking care of those patients.
Well, thanks for having us. We appreciate it.
All right. Well,
Thank
thank
you
you
so
so
much.
much. Have a great afternoon. Thank you.